Okay, so I think that's pretty much everyone we're going to get signed on just now, and we can just get going, and I shall pass you over to Ellen.
Hello and welcome to this Living Well with Myeloma session on peripheral neuropathy. So I get calls to the Myeloma Information on a daily basis about peripheral neuropathy. It's often poorly understood but can have a huge impact on a patient's quality of life. During this webinar, I'll do my best to describe what peripheral neuropathy is, what the most common symptoms are, why it occurs in myeloma, what can be done to treat it, and including some self-management tips and future treatment developments. So going on to the first slide. So first of all, we'll look at the definition of peripheral neuropathy. Many people will not have heard of peripheral neuropathy. What it means is damage to the nerves of the peripheries or the extremities, most commonly the hands and the feet. The nervous system of our body is made up of the central and the peripheral nervous system. The central nervous system is our brain and spinal cord. The peripheral nervous system consists of all of the other nerves, and these carry impulses to and from the central nervous system. The peripheral nerves are made up of nerve cells called neurons. Sensory neurons transmit impulses to the brain and enable you to feel sensations such as hot, cold and pain. Motor neurons control muscles, allowing movement, touch and grip. Autonomic neurons regulate the autonomic functions of the body, such as blood pressure, and the function of internal organs, such as the bladder. So let's look at the most common symptoms of peripheral neuropathy. Peripheral neuropathy can be quite debilitating and in some cases can be permanent, and this is why doctors and nurses take it so seriously. Symptoms of peripheral neuropathy can vary, of course, from patient to patient. Some patients won't have any issues with peripheral neuropathy at all, but the symptoms I'm going to describe are what we hear most commonly. Looking at the different types of peripheral neuropathy, and bear in mind that patients can have a combination of all types. Damage to the sensory nerves. Remember, these are the nerves which carry information from the peripheries to the central nervous system. This is perhaps the most common type of neuropathy in myeloma. It can be very uncomfortable and distressing and mostly affects the hands and the feet. Symptoms of this type of peripheral neuropathy may include numbness, tingling, sensitivity to hot or to cold or heat and pain. Many people will describe their symptoms as pins and needles, shooting pains, burning, very sensitive to touch, altered sensations. Many patients say they feel as if they're wearing gloves and socks when in fact they aren't. Damage to the autonomic nerves, the nerves that can control functions not under our conscious control, such as the blood pressure, the heart and digestion, can lead to lowered blood pressure with symptoms of dizziness and lightheadedness. Some patients even feel quite faint, especially when they sit up or stand up quickly from a lying down position, and that is called postural hypotension. Hypotension means low blood pressure. Autonomic neuropathy can also cause sudden changes in heart rate, diarrhea or constipation, and some patients may suffer from incontinence or impotence, and others may find that they sweat more. Damage affecting the motor nerves, the nerves that carry information from the central nervous system to organs, muscles and glands, may cause symptoms of muscle weakness, muscle twitching, painful cramps, and decreased stability when walking. Doctors and nurses may use terms such as predominantly motor neuropathy, predominantly sensory neuropathy, sensory motor neuropathy, or autonomic neuropathy to describe the type of nerves involved in an individual's situation. So moving on to explore some of the known causes of peripheral neuropathy. Up to about 20% of patients will have symptoms of neuropathy at diagnosis. The peripheral nerves are fairly delicate and are very sensitive to direct damage from the abnormal protein produced in myeloma, that's the paraprotein or the light chains, or to damage due to hyperviscosity, which is where the blood can become thicker than it should be due to the high levels of the abnormal protein. And this can lead to poor circulation and a lack of good blood supply to the peripheral nerves. If a patient has kidney damage, this can also cause peripheral neuropathy, as the kidneys remove toxins from the body, and the delicate nerve cells can be very sensitive to this. Neuropathy caused by the myeloma itself can resolve once treatment brings the myeloma under control. However, as many as 75% of patients will experience some peripheral neuropathy as a result of their treatment. The drugs most likely to cause peripheral neuropathy are Velcade, thalidomide, and the chemotherapy drug vincristine. Vincristine isn't used that much in myeloma these days. It still is used, but not as commonly as it used to be. The newer versions of these drugs, the newer versions of Velcade and thalidomide, like Kyprolis, Ixazomib, Revlimid and pomalidomide, are also culprits, but to a much, much lesser extent. Other causes of peripheral neuropathy might include a condition called amyloidosis, where the damage would be due to the light chains, poor thyroid function, or other conditions such as which cause fluid retention, which poor thyroid function does. Fluid retention isn't a good idea. That can cause your nerves to be very sensitive to damage. Shingles and diabetes are also commonly cause peripheral neuropathy, and sometimes people who take too much alcohol for a prolonged period of time, or have a poor diet and experience vitamin deficiencies, can experience peripheral neuropathy, or indeed that can make existing peripheral neuropathy worse. So it's not always related directly to the myeloma or its treatment, so should always be taken seriously and investigated very thoroughly. So I have a couple of slides now on the treatment and management of peripheral neuropathy. Peripheral neuropathy is perhaps one of the most challenging problems in myeloma to assess and manage, because it relies almost entirely on patients reporting their symptoms and how it might be impacting their everyday life, from simple tasks like fastening a button on a shirt or opening a jar, to pain that affects mobility and interferes with sleep. Realistically, patients should be assessed before starting any treatment which is known to cause peripheral neuropathy. The initial assessment should identify patients who are at increased risk, or those who have a pre-existing neuropathy for whatever reason. Thereafter, regular assessment should be made before the start of each cycle of treatment, and that means that any emerging or worsening symptoms can be picked up as early as possible. Assessment should continue even after treatment has stopped. I know that sometimes peripheral neuropathy can be a bit of a delayed reaction. And of course doctors, as well as nurses and doctors making regular assessments, asking patients about their symptoms. It's really important for patients to be vigilant too, and to report any new or increasing symptoms promptly. If peripheral neuropathy develops, some patients may benefit from nerve conduction studies to determine the type and extent of nerve damage, and to identify if there's any possibility of improvement. Probably the first step in treating peripheral neuropathy is to identify the cause. If it's myeloma related, treat the myeloma. If it's due to treatment for the myeloma, then dose adjust or stop the treatment. It might be necessary. Hi folks, I'm sorry we've had some technical problems here. I think our internet just dipped out and that meant that we lost you temporarily. We are back. Hopefully you can see our slides again and you can hear me. We'll get back on track in just a couple of seconds. Please bear with us. Probably the first step in treating peripheral neuropathy is to identify the cause. If it's myeloma related, treat the myeloma. If it's due to treatment for the myeloma, then dose adjust or stopping the treatment may also be necessary. I know that this is what worries patients the most. They're on a treatment that is bringing their myeloma under control and will put up with a lot for that to continue. This makes some very reluctant to mention symptoms if it means that their treatment will be stopped. But it is worth bearing in mind that if dose adjustments are made, there can still be a good response to a lower dose of the drug. If treatment is stopped, sometimes it's only a temporary measure, and often patients can restart treatment, perhaps at a bit of a lower dose with closer monitoring. So please don't suffer in silence. Do let your doctors and nurses know if you're having symptoms of peripheral neuropathy. Once the cause of the peripheral neuropathy has been identified, then it's important to treat the symptoms. Pain control is very important and can help maintain a good quality of life. However, sometimes the usual painkillers, even the strong morphine-based ones, may not be effective, although they are in some cases. Sometimes drugs licensed for other uses, which you might not think of as normal treatment for pain relief, such as the antiepileptics, gabapentin and pregabalin, and the antidepressants amitriptyline and duloxetine, are often very effective in reducing the symptoms of peripheral neuropathy. So don't be alarmed if you find that you're prescribed one of these drugs. They can be very effective. I know patients tell me that topical creams often help, so cocoa butter based moisturisers, menthol or pepper based moisturisers massaged gently on a daily basis can often be very helpful. Sometimes pain relief patches are used. These pain relief patches rely on a local anaesthetic agent, and they're good for particular areas that are causing problems. Transcutaneous electrical nerve stimulation, or TENS, or percutaneous electrical nerve stimulation, or PENS, machines can sometimes help. These are machines that deliver tiny electrical impulses. However, unfortunately, if the nerve is damaged completely, then these machines won't help. Some patients do benefit from taking a vitamin B supplement. Our healthy nerve cells do need vitamin B to function properly. However, more serious cases might need to be referred to a palliative care expert. A palliative care expert's focus is managing the complications and symptoms of myeloma and its treatment to improve quality of life. Sometimes a palliative care expert can think of something that perhaps the doctor hasn't thought of. I know patients often feel concerned that palliative care means end of life, but really that absolutely isn't the case. So again, please don't worry if a referral to palliative care is made. They are experts in managing complications and symptoms. For the vast majority of patients, peripheral neuropathy is reversible, provided action is taken early. Unfortunately, if sensation has been completely lost or it's for a long period, it is unlikely to return, and that's why it's so important to report things promptly. There are many things that patients can do to help ease the symptoms of peripheral neuropathy, and here are some self-help tips that we've been told that patients have found helpful. Please be aware that if you have a loss of sensation in your hands and feet, then there is a potential for injury. Get someone to check the bath water isn't too hot, for instance. If your feet feel numb or strange, then you might be at risk of tripping. That, along with a loss of confidence in walking, could increase your risk of falls. So do things like ensure dark rooms are well lit, that floors are clear of trip hazards, and that you've got comfortable, well-fitting shoes or slippers. You can also get aids to help you with jar lids or bottle lids, or to help you fasten up buttons in shoes. So speak to someone from the occupational health team at the hospital you attend. If you do have peripheral neuropathy, a chiropodist should really be the only person that cuts your nails or deals with corns or other problems with your feet. So again, ask for a referral to a chiropodist and keep an eye on your feet and do report any problems with them. Smoking isn't good for the circulation, so if you do smoke and can manage to stop, you'll be doing yourself a big favour. And peripheral neuropathy in the feet can affect your ability to feel the pedals in your car. So if your peripheral neuropathy is quite severe, then you really should be notifying the DVLA, who may ask for a report from your doctor. So looking at the future, hopefully the newer drugs for myeloma, the ones that are in development in clinical trials, will carry less side effects, and the more drugs are developed and the newer drugs that come along, that is the case. Because we know, for instance, that the newer versions of thalidomide, the newer versions of Velcade have lesser risk for causing peripheral neuropathy. And drugs can also be given in a slightly different way. Again, when Velcade was first introduced, it was given as an intravenous infusion rather than an intravenous injection. Subsequently, it's been made to be a subcutaneous injection, which means it just goes under the skin, a very small injection under the skin, and that has been shown to potentially cause less peripheral neuropathy. And that's the end of my presentation. I'll hand over to Rebecca.
Okay, thanks very much, Ellen. Hopefully you got everything that we said today. Obviously we had some technical difficulties, so we apologise for that. We'll be sending out the recorded webinar, which will have all the information just in case you missed it. Ellen mentioned quite a few resources that might be helpful to you. They're on the screen just now. We'll also send out a link to those as well. And thank you very much for your questions so far. I know we've had a few already. Just while we're waiting to get that, I'm going to have a look at some of the questions on our screen. You won't be able to see them at the moment, but we'll be able to give you some while we're trying to sort out our technical difficulties. So our first question comes from Nina. She says, I already have peripheral neuropathy in my feet. Is there a chance it could also spread to my hands?
Thank you, Nina. Peripheral neuropathy doesn't really spread as such. However, I think, as I mentioned earlier, someone who has existing peripheral neuropathy is at risk of that being made worse when taking treatments that can cause neuropathy. So it is something that your doctors and nurses will take very seriously should you need to start on further treatment that potentially could cause neuropathy. So do let your doctors and nurses know. And it doesn't do any harm to keep quite vigilant about your existing neuropathy. Keep a diary, let your doctors, let your nurses know. But strictly speaking, the answer is no, it doesn't spread as such, but it could be made worse by further treatments, yeah.
Okay, thanks very much, Ellen, and I hope that answers your question, Nina. We've also got a question from John, who says, can hot or cold temperatures affect peripheral neuropathy and can either help relieve the symptoms as well?
Yeah, certainly patients with neuropathy are very sensitive to hot and cold, and sometimes they don't feel sensations of hot and cold, and that's why I said earlier, be very careful that you check the temperature of your bath or your shower, and that you don't go touching hot pans when you're cooking and things, because you might not be able to feel those sensations particularly well. Strictly speaking, hot and cold doesn't affect the neuropathy, so it doesn't make it any worse. So that's not the case. But some people do find that a warm, some of these warm wheat-filled bags that you put in the microwave are quite pleasant on your feet. As long as they don't get too hot, they can sometimes help. But yes, patients might not be very, very good at feeling hot and cold, so just be a little bit careful.
Okay, thanks very much for your question, John. We're going on to Susan now. She says, I find that 600 milligrams of alpha-lipoic acid helps my peripheral neuropathy. Is there anything else I could or should take?
Yeah, I've heard patients tell me before that alpha-lipoic acid helps. It's a supplement, and there are some supplements that patients have told us can be quite helpful. I would always say run it past your doctor or your nurse specialist. And there isn't any stringent evidence in clinical research in patients with myeloma, but anecdotally I have heard that this can help. And again, it's the same with the vitamin B complex. As I said earlier, healthy nerve cells do function well with vitamin B, so sometimes a vitamin B complex supplement helps as well. Have a look at our information sheet on peripheral neuropathy, and it gives you some ideas about what else patients have told us they found helpful. So yeah, it may be helpful. We don't know for sure, but do let your doctor or nurse know.
Okay, thanks very much for your questions, Susan. I hope you found that helpful. You can also submit any questions at any time just now. You can just find the questions tab on your GoToWebinar viewer window, or if you're on a smartphone or a tablet, remember you're looking for the question mark icon. Okay, so our next question is from Derek. He says, I'm finding it hard to grip a knife and fork properly when I eat. Is there anything I can do that will help?
Well, that's something we do hear about, Derek. You can kind of lose your grip, if the motor nerves are affected. Grip can sometimes be affected and not be as good as it was. There are things you can get to help. Again, perhaps someone from the occupational therapy department at the hospital you attend can help you with, you can get big chunky covers that you put over knives and forks that make them a bit chunkier, like big foamy covers. And you can get plates that have a bit of a dip in them. There are quite a few various accessories that are available. So hopefully your grip will improve over time, and it usually does. But in the meantime, if you're struggling, please do speak to someone from occupational therapy at the hospital and ask about these accessories to help. And even things like rails to get in and out of baths, up and down stairs, help you on with your socks and things like that. There are quite a few pieces of equipment, very simple pieces of equipment that might be helpful.
Okay, I hope that answers your question, Derek. We'll also be sending out the resources list at the end of the webinar in the email. Okay, so our next question says, when I was taking Revlimid, I experienced a very numb tongue, the feeling you get when a dental local anaesthetic is wearing off. Would this have been neuropathy?
I don't think so. I don't think this is neuropathy. It's not something that I've heard of. I know that patients sometimes get numb jaws, numb teeth, sensations of numbness when they're on the drug to protect their bones. The zoledronic acid or the pimidronase can cause a bit of numbness in the jaw and the tongue. I wonder if it might be something like that. Or, and again, unfortunately, patients are quite susceptible to sore mouth. So if you've got a bit of an ulcer on your tongue, if you've got a sore tongue, it perhaps gives a sensation of numbness. Any swelling can cause numbness. So, for instance, patients who have amyloidosis often have swollen tongues, and that can cause numbness, or it may be an allergic reaction. But sometimes, doctors and nurses aren't able to say why you've got a symptom. So it's one of these things that sometimes there isn't always an answer for. But in my experience, this probably isn't neuropathy. But again, do mention it to your doctor or your nurse specialist. Yeah.
And thanks for sharing that with us. We'll move on to our next question in a second. Okay, the next question comes from Nicola. She says, I understand neuropathy associated with thalidomide is as a result of a cumulative dosage. Is this the same case with lenalidomide and pomalidomide as well?
That's a really good question, Nicola. Yeah, so you're right. Sometimes side effects of treatment are cumulative. So the more you have of a drug, the more likely you are to have side effects, and that is the case with many side effects. We've said that the newer versions of thalidomide are developed to be more potent with less side effects, and that is the case. So lenalidomide and pomalidomide are derivatives of thalidomide, and they're developed to be more potent with less side effects. Unfortunately, they in some cases they can still cause some peripheral neuropathy. It's less likely, but it can still happen. And yes, Nicola, you're quite right. The more you have a drug, the more likely you are to have problems with side effects. So again, it's important for you to be quite vigilant and not to suffer in silence. And if you're feeling any sensations or symptoms that you think might be neuropathy, do let your doctor or your nurse know. So you're absolutely right.
Thanks very much, Ellen, and I hope that answered your question, Nicola. Our next question comes from John. He says, what's considered to be too much alcohol? I do enjoy a couple of small glasses of wine in the evening. Is this okay long term?
That's fine. I think when we talk about alcohol potentially causing damage to the peripheral nerves, we're talking about people who perhaps have an alcohol problem, who have had an alcohol problem for years, and who are on lots and lots, they take lots of alcohol. They're heavy drinkers over a long period of time. A couple of small glasses of wine in the evening might even well have some benefits. Excuse me. So help you digest your meal, help you relax in the evening. Really, I mean, I guess if you're taking a glass of wine regularly, it doesn't do any harm to be aware that potentially it could make your any existing neuropathy worse, and just be, pay attention to it. But I think a couple of glasses of wine in the evening is absolutely fine. But as I say, just be quite vigilant yourself.
Okay, so that's good news on the wine front, which is good to know.
Yeah.
Thank you very much for your question. Our next question comes from Tim. He says, once you have neuropathy, can you get rid of it ever completely?
Yeah. Usually, as I said earlier, Tim, neuropathy is reversible. So most patients do recover fully from neuropathy if it's identified quickly and if it's dealt with promptly. Unfortunately, some patients can have a degree of long-term neuropathy. Some patients are left with a little bit of tingling in their fingertips or a little bit of numbness in their toes, and that can be permanent. And because it can be permanent, that's why we do take it, as healthcare professionals, we do take it very seriously. But on the whole, it does improve. In some cases, it can take quite some time for patients to see an improvement. I speak to patients on the end of the line who 4, 5, 6 weeks after stopping their treatment have still got some neuropathy. So it can take quite a few weeks in some cases for patients to see an improvement, but mostly they will. It would be very, very unfortunate for someone to be left with severe permanent neuropathy. That's pretty rare. Again, that's why it's so important for you to be promptly reporting your symptoms, Tim.
Yeah. And I'm just wondering, Ellen, there can be cases where people change their treatments. Is there a chance that you can get neuropathy from a different type of treatment, and that can be completely unrelated to the first bout? Is that
yes, possible? It is possible. I guess as we know, there are different types of neuropathy. There's sensory, motor and autonomic neuropathy, and some of the drugs are perhaps more likely to cause one type rather than the other. Usually it's a combination of all of these types if someone's going to have neuropathy. So yes, the neuropathy perhaps caused by Velcade might be slightly different to the neuropathy caused by thalidomide. So it doesn't always follow that if you've got neuropathy caused by thalidomide and you're about to start Velcade, that it absolutely will exacerbate or make make neuropathy worse or for it to come back again. It doesn't follow, but it's possible, and doctors and nurses will take that very seriously, and when you're being assessed before you start treatment or before each cycle, you will be asked about previous cases or previous conditions or previous experiences that you had with neuropathy.
Okay, thank you very much. Okay, so we'll look to our next question now. This one comes from Matthew. He says, I have severe peripheral neuropathy in my feet, and I found that the medications prescribed also have strong side effects, which are listed on the screen. And I think there was some of the painkillers you'd mentioned earlier, Ellen. Yeah. Is there any hope for better pain relief for neuropathy in the pipeline?
Yeah, no, that's really good, Matthew. I mean, unfortunately, there isn't a drug available today that potentially doesn't come with its own share of side effects. And these drugs to treat the neuropathy, the pregabalins, the duloxetine, the amitriptylines, the gabapentins, can in themselves have some side effects, dizziness, nausea, things like that. I think the mainstay of neuropathy is to prevent it. So, prevention is always better than cure. So developing newer drugs that don't have the potential for causing neuropathy is really, really important. But to treat the neuropathy itself, yes, there are always improvements. In fact, pregabalin, for instance, is perhaps a newer, more sophisticated drug than gabapentin. Duloxetine is something that's used perhaps if amitriptyline isn't working. So there's always there are always other options. Some of these drugs you do build up the dosage to get the best effect from them, and you would start off, for instance, with the pregabalin and the gabapentin, you would start off at a fairly low dose and gradually increase it. And at that time, whilst you're increasing that dosage, you would be monitored for side effects from these drugs. But yes, it is a bit unfortunate that some people do have problems with side effects from the treatment that are helping with side effects. But yes, improvements are happening all the time. So yeah, it is something that researchers, doctors, scientists are very aware of. Quality of life is something that absolutely is a priority.
Okay, thanks for that, Ellen. Matthew, if you do want to discuss this further, you can always call the Myeloma Info line, and we'll be sharing the number at the end of the seminar again. Where our next question comes from Roger. He says, you mentioned if your presentation of peripheral neuropathy is serious, you should report it to the DVLA. How do you define serious?
Yeah, no, that's a good point, Roger, yes. So peripheral neuropathy can be graded, and when doctors and nurses are assessing any existing peripheral neuropathy, they ask a series of questions to grade it. So grade 1 would be no existing neuropathy, grade 2 would be very slight tingling or numbness. So when you're assessed, your doctor or nurse will be able to tell you what the severity of your neuropathy is. And I think if and when you do report it to the DVLA, they may well contact your haematologist just to ask. I was speaking to a gentleman the other day on the info line who called the DVLA, and the DVLA simply said to him, if you can't feel the pedals, don't drive. So, and of course that obviously doesn't affect people who have mobility cars, who use hand controls and things like that. So I think you've got to be, there's a degree of common sense to it as well. If you feel that your peripheral neuropathy is affecting your ability to drive, then don't drive, and report it to the DVLA. You can probably drive if your neuropathy is quite mild, if it is just sensations of tingling or some slight numbness. But if you're having problems walking or gripping, then that's slightly more severe, and maybe you may be a bit of a risk when driving. So perhaps before you were to report it to the DVLA, it might be an idea to say to your haematologist, this is what I'm experiencing with my neuropathy, should I be reporting it to the DVLA? Grade, very, very mild neuropathy, you don't need to report that. But, you know yourself better than anyone. You know what's normal for you. So, I think common sense is really important.
Okay, thanks, Anne. I hope that clears that up for you a bit, Roger. Our next question comes from another John. How long after stopping Velcade treatment should I still suffer from peripheral neuropathy?
Yes, no, as I said, sometimes it can take some time for it to wear off. I mean, the drug should be out your system within 2, 3, 4 weeks at most. However, peripheral neuropathy can continue for some time after that. And I have spoken to patients, in fact, for whom the neuropathy's got a little bit worse before it got better. They say to me, I've been off Velcade for 2 weeks, my neuropathy is worse than it was. But it should start to improve. And again, keep reporting it. If you've already reported it once, don't worry. Repeat yourself if necessary. But I would say that if things aren't improving, it may take several months. If things aren't improving 3, 4, up to 6 months, then that could be quite severe. But certainly things should certainly be improving within 2 or 3 months. You should notice some difference.
Okay, thanks very much, Ellen, and thanks for your question, John. We've got roughly about 5 minutes left, and we've got a couple of questions. If you still want to get yours answered, you can still submit at any time. Just use the questions tab on the GoToWebinar viewer window, and remember, if you're on a tablet or a smartphone, to look out for the question mark icon. Our next question comes from Barry. He says, I suffer neuropathy in the feet and fingers and go to balance classes to try and improve my sense of balance and reduce the number of falls. Am I wasting my time?
You're not, Barry, absolutely not. I think the benefits you get from this class are well over and above getting on top of your any neuropathy. I think it's a good idea to try and improve your balance, and not and you won't just be improving your balance with these classes, you'll be improving things like your muscle tone, and it's always good, well-toned muscles are a good thing anyway. They will give you more confidence when you're walking, and it's also very good for your feelings of self-esteem. You're doing something that's helping yourself, so that's never a bad thing. So I wouldn't say you're wasting your time at all, Barry. Even if you don't feel that it's having a direct effect on your neuropathy, it will be having positive benefits in many other ways. So keep it up, yeah.
Okay, fantastic. Thanks very much, Ellen. Okay, so our next question comes from Rita. She says, what quantity of the various vitamins are recommended? I'm already taking a pan-vitamin supplement because I think it helps, but would like to know if there's a particular amount or type you should be taking.
Well, really, I mean, basically we should be getting all the vitamins and nutrients we need from our diet. A healthy, well-balanced diet should be giving us all the vitamins that we need. But as I said earlier, nerve cells particularly function well with vitamin B. They quite like vitamin B. So I think vitamin B is probably, if your doctor was going to suggest you take a supplement to help with your neuropathy, it would be the vitamin B complex. And there's various vitamin Bs in that complex. There's vitamin B12, vitamin B1, and I think those are probably the ones that are perhaps more beneficial specifically in neuropathy. So I'm not sure what level or dosage of vitamin B the pan vitamin has in it. You could maybe have a look at the information leaflet that you get with it, or even speak to the pharmacist where you bought it, if you bought it over the counter at a chemist, for instance. But patients can sometimes be prescribed vitamin supplements. So again, it wouldn't do any harm just to mention it to your doctor or nurse. But I think to answer your question, it's probably the B vitamins that are best specifically in neuropathy.
Okay, thanks very much for your question, Rita. I think we've just got time for a couple more questions. I think we've got roughly one or two. We've got one from Elizabeth here. She says, my blood pressure is 80/60. Is this a form of peripheral neuropathy?
That's a bit on the low side, Elizabeth, that blood pressure. It's what we call hypotensive, low blood pressure. However, when neuropathy causes a drop in blood pressure, I said earlier, it's called postural hypotension. Hypotension means low blood pressure, and postural means the position your body's in. So what we commonly see is that a patient's in autonomic neuropathy is that a patient's blood pressure will drop suddenly when they get up from a lying down or a sitting position. So if someone gets up suddenly from lying down, they may feel as if they're going to faint or pass out or feel very, very giddy and very weak. And that is the common symptom of postural hypertension in autonomic neuropathy. If you've got constantly a blood pressure of 80/60 and it doesn't drop to that level suddenly, and again it's something that nurses measure quite frequently. If you go to the clinic and you say you're giddy or dizzy when you stand up, they will want to check your blood pressure in a lying position and then check it immediately in a standing up position just to see if there is that drop. But if your blood pressure is constantly at that level, that may be your normal, although it is very low. I would suggest that maybe you try to drink plenty of fluids. I don't know if you're maybe on a blood pressure tablet. I mean, that is quite a low blood pressure, but it might be just that's what your blood pressure is. But yeah, keep drinking plenty of fluids and mention any dizziness, any giddiness, any weakness. If you feel you're going to fall over, let your doctor or your nurse know.
Okay, so that's a few bits of advice there, Elizabeth. If you do want to talk about that further, you can call the Myeloma Info line. We're just a few slides away from sharing that number again, so that might help. Okay, so our last question comes from Trudy. She says, I suffer really painful muscle cramps and spasms from time to time. Do you have any tips to combat this? I'm currently on lenalidomide, which I'm assuming may be the culprit.
Yes, that's a tricky one, Trudy, because it might be the lenalidomide, it might be something else. Muscle cramps are sometimes, it might be neuropathy, absolutely, and it's a good idea to keep a diary as well. So note down where the cramp happens, what you were doing before and what you were doing after, where in your cycle. So try and keep a bit of a good diary, and let us know if you want one of our patient diaries. I can pop one out in the post to you. But I was just going to mention that sometimes the normal healthy salts in our body can get a bit disrupted. So when you have blood taken, you'll have things measured like potassium, magnesium, sodium, calcium, things like that. Those are normal healthy salts that we have in our blood at a normal healthy level. And if they're a bit awry, then you can suffer things like muscle cramps or spasms in your fingers or things like that. So check with your doctor or your nurse if any of these salts are a bit on the low side. Sometimes if calcium's a bit low, you can have muscle spasms. So it might not strictly be neuropathy, but it wouldn't do any harm to explore these other potential issues as well, Trudy. Do ask about that.
Okay, thanks very much for that, Ellen, and thank you for your question, Trudy. I think that's all the questions we have time for, as we're running a little bit over at the moment. If you do have any additional questions, you can get in touch with us still at any time by emailing asktheNurse@myeloma.org.uk, and you can also give our Myeloma Information Specialist a call on the Myeloma Info line. The number again is 0800 980 3332, and you can call that for free from the UK during office hours. If you did find today's webinar helpful, you also might find our upcoming webinars helpful as well. You can check those out at myeloma.org.uk/webinars, and our next one takes place in August, and we hope to see you then. Thank you. Bye.